Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a man of 45 years of age, smoker and regular consumer of cannabis and cocaine, without backgrounds of ischemic heart disease. He arrives at our unit with a diagnosis of non-ST segment elevation myocardial infarction, also known as NSTEMI, of approximately 5 hours of evolution. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! In this electrocardiogram, we have the next alterations. First, complete right bundle branch block. Second, prominent R waves on right precordial leads with descent of the ST from V1 to V4. And third, Q waves on high lateral leads 1 and AVL. These changes could be read as a NSTEMI, which corresponds to an acute myocardial lesion of subendocardic characteristics in the left ventricle in relation with an ill coronary artery, but still open. However, many times ST descents on V1 to V3 can be a mirror image of transmural infarcts of the lateral wall, classically known as posterior infarct, which tend to go unnoticed for not having an obvious electrical expression on conventional leads. For all this, it was considered, in this case, that we had a lateral or posterior STEMI. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, right coronary artery is open and lesion-free. However, this projection shows us something more than the right coronary artery. Do you see it? Yes, it is the circumflex, whose distal bed is filled retrogradely by heterocoronary collateral circulation, which suggests an occlusion of the antegrade flow of this artery. Let's take a look at the left coronary tree. As you can see in this projection, circumflex is blocked at its proximal segment, which results common on lateral or posterior infarcts. Now that we know where the obstruction is, treating it is the only thing left. First, we will have to pass an angioplasty guide wire through the closure. Sometimes passing the guide wire partially opens the artery and allows us to see the distal bed. However, this is not the case. Thus, a thromboaspiration catheter was used with the intention of extracting part of the thrombotic content and unblock the artery. However, this maneuver failed because of having trouble navigating the catheter through the obstruction. For this motive, the stenosis was pre-dilated with a semi-compliant balloon. Blood flow was restored with it. However, in this projection, a secondary reperfusion defect can be noticed. Do you see it? Yes, we are talking about bradycardia. If you pay attention on heartbeats, you will be able to notice that heart frequency clearly decreased. And this, along with arterial hypotension, is a result of a vagal activation process. Because of this, we administered half a blister of atropine, and after a few minutes, we got this retrieval of arterial pressure and reflex sinus tachycardia. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!